am now delighted to introduce our speakers for the first Young Investigators Symposium. I find the work of pediatric surgeons who are at the beginning of their careers is particularly exciting and inspiring. We invited these 4 young investigators as representatives of the true variety of work in our field. They come from an array of geographic areas and different types of institutions. Each of them has focused on one of a broad array of topics for the study. Each of them has met the high bar for NIH funding, each via a different mechanism, which I hope will prove informative for those contemplating this path. Each of them will briefly present their work and then describe their experience in developing this work to get to this point. I have asked them to focus on 3 questions. How did they arrive at the question they chose to ask? Who and what did they find helpful? And what obstacles needed to be overcome? So without more ado, I'd like to invite Dr. Brian Booker, Dr. Lorraine Kelly-Kwan, Dr. Chetan Sathia, and Dr. Lindsay Talbot to join me here. Dr. Booker will be our first speaker.
On behalf of my co-presenters, I would like to thank President Kendall, the board, and the APSA Research Committee for the privilege of the podium today. And for the next 8 minutes, I will talk to you about my story going from the bench to the bedside to the EHR and my career development in surgical informatics. I have no disclosures to report other than I have received funding from the Agency for Healthcare Research and Quality, a KO8 award, which has led to my invitation here today to talk about my story. 10 years ago, I was privileged to sit in this auditorium when President Kendall then gave her Grossfeld lecture to talk about serendipity and her path towards her career. And so with all due respect to President Kendall, I would like to describe my path as Serendipity Plus, which include four components: identifying opportunities, leveraging institutional strengths, seeking out mentorship, and maintaining perseverance. So when I was a resident in the lab, I spent a number of hours in the old medical records department in the hospital, manually reviewing charts for APSA abstracts. At the same time, the American College of Surgeons developed the National Surgical Quality Improvement Program to improve surgical quality and safety in the United States. And at the same time, those NISQIP reviewers were doing the same thing I was doing, pulling charts and manually reviewing the medical record. And I thought to myself at that time, there has to be a better way to do this. There has to be a better way to get information out and easily accessible to investigators. Coincidentally, over the past 10 years, we've seen a huge increase in the adoption of electronic healthcare records in the United States. And if you overlap this with my career path, when I finished fellowship, there had been a shift from manual medical records to electronic healthcare records. And this shift has created an opportunity to leverage electronic healthcare data to improve surgical care. And so my first recommendation on identifying opportunity was that I was able to come out at a point where I can use EHR data to improve the surveillance of surgical complications. Second point of serendipity is that you need help. And so I happened to be recruited to an organization that was very strong in informatics. Everyone's worried about AI in healthcare. This article was from 1961, showing how an AI system can improve the diagnosis of congenital heart disease in children better than clinicians. And this was published by our founder of the Biomedical Informatics Department at the University of Utah. Next, and I won't belabor the point, but you need mentorship, and you need to aggressively seek out mentorship. I've had a number of mentors during my early career who range from informaticists to psychologists to surgeons to pediatric surgeons. If you want to be a surgeon scientist, you need mentorship in both surgery and science, and I can't stress that enough. So our group uses natural language processing, which is an artificial intelligence technique to extract data from free text and convert this data to a structured format that can be read by a computer. And so the way our lab works is we extract data from the electronic healthcare record, we train AI and NLP models to identify complications, and then we validate models with actual labels. And another point of serendipity is I was fortunate enough to work at 2 institutions, and so I have access to 2 different EHRs, and I can develop and train models in 2 different healthcare systems. So the way our processes work is we take electronic healthcare notes, all the notes after surgery, we break the notes down to individual notes, individual sentences, and then we do NLP to identify the important concepts, and then at the end of the day, we make a determination whether the patient had a complication or not. And we focus on the big 4, surgical site infections, venous thromboembolisms, and urinary tract infections. And then we compare our NLP models to the NSQIP program. And so we've done this for 4, as I mentioned, 4 complications: SSIs, UTIs, PEs, and DVTs. As we're doing surveillance, we care about sensitivity because we want to identify all the cases. And so as you can see here, models trained at one institution have a high sensitivity between 88% to 100% for various complications. And on the right-hand side, you can see the overall accuracy as measured by the AUC. The more exciting component is that we take our same models and blindly, just plug and play, put them in a different hospital. And they actually perform as well as our models that were developed at the University of Utah, with high sensitivity and high specificity. So we've wrapped these NLP models in a software platform called Scout, Surgical Complications Outcome Tracker, which automatically extracts data from the EHR and then presents users with the NSQIP outcomes at the push of a button. And so users at the University of Utah can log in, see NSQIP outcomes in real time, and then if they need more information, we can actually drill down to the actual data points in the notes, in the charts that provide this information. Cool next steps is we've been very, very good at learning how clinicians speak about complications, but we want to know how patients speak. So we've actually started developing an AI chatbot that will interact with patients and reach out to patients after surgery and perform remote monitoring after surgical procedures to be able to identify complications earlier and hopefully prevent unnecessary sequelae such as readmissions and reoperations, et cetera. So I'm very excited because maybe next year ChatGPT can give this talk rather than me. The biggest obstacle that I've struggled with, and I think most of us struggle with, is perseverance. We all come to APSA, we see people present their best science here, and we see the successes and not the failures. And so maintaining perseverance is key, and I will be the first one to state that I am not perfect. And to be honest, this is my ERA Commons grant success rate, and you can see there's lots of reds, very little greens. And so maintaining perseverance in the face of adversity, which I would consider ERA Commons adversity, is a technique or a skill set that I still struggle with to this day. However, I'm optimistic, and if you'll allow me one more minute, I will suggest names for next year's Grossfeld lectures. These are kind of 3 individuals who are up-and-coming informaticists who are pediatric surgeons. Pepe Diaz-Morone is in Colorado and doing some really cool time series analysis for clinical deterioration. Jamie Robinson is at Vanderbilt and is looking at EHR, GWAS genotype association studies. And then Aaron Lesher is at MUSC, and he does some really novel telehealth and outreach. So these are kind of a community of informaticists within APSA that I would be excited to see what happens with in a year. And with that, I will stop, and thank you all for the privilege of the podium.
Dr. Kelly Kwan.
All right. All right, good morning, everyone. Thank you so much for the opportunity to present, and especially thank you to Dr. Kandel for this incredible opportunity for young investigators. I'm trying to revel in the amount of time I still get to be called young at the podium, so I'm just savoring this.
As long as you're younger than I am, you're young.
All right. All right, as many of you know, I did my pediatric surgery fellowship at Nationwide Children's Hospital. So I was there from 2015 to 2017. And if you were tracking the opioid epidemic, that's really when it came to its height. Ohio was hit very hard by the opioid epidemic. And in addition to learning the craft of pediatric surgery, I also very much appreciated how it impacted the communities I was serving. But I also noticed something else. I noticed that we give babies in the hospital a lot of opioids. Hospitalized infants frequently receive opioids for procedural sedation and analgesia, for intubation, and very commonly after surgery that we perform. And something that I didn't know until I went to fellowship was that sometimes infants receive such a long course of opioids, they become physiologically dependent on opioids and require methadone therapy. This was something that I really didn't know existed in infant care, and I think it's something that the general population also isn't really aware of. When people think of methadone, they think of adult methadone clinics. So I dug into the literature a little more. It turns out decades ago, clinicians didn't think that infants actually experienced pain. And it wasn't until seminal work in the 1980s that demonstrated that if an infant experiences a painful procedure and doesn't have sufficient analgesia, they will have poor neurologic outcomes and increased morbidity. Then in 1999, the No Pain trial results were published. So this was a multi-center RCT in which they enrolled premature intubated infants. These were not infants undergoing surgery. These were just premature neonates in the NICU. And they randomized them to receive either a preemptive infusion of morphine or placebo. And what they found was that the infants who received a preemptive infusion of morphine actually had improved neurologic outcomes. Now, I want you to then look at the graph I have on the right side. So this graph shows the US oxycodone consumption per capita from 1980 all the way up to 2015. And you'll see that the No Pain trial came out right in the midst of the uptick in overall opioid prescribing in the US, which correlates with the pain is the fifth vital sign movement, which also correlates with the mass marketing of OxyContin. Fast forward 5 years later, the NeoPain trial was then conducted. This is the same trial parameters, a larger cohort, but they actually found that infants that were randomized to morphine didn't actually have any different outcomes than the ones who were randomized to placebo. But fast forward to today, this is data out of my lab. Opioids are commonly used for hospitalized infants. So this is data that's generated from the Pediatric Health Information Data Set. Many of you use this data set. It's an administrative claims data set. It draws data from 53 children's hospitals in the United States. So it represents 20% of pediatric hospitalizations and 50% of critically ill children admitted to the hospital. So these are the kids that we're taking care of. And what you'll see here, so we evaluated 2 million hospitalized infants from 2005 all the way up to 2015. And we found that 20% of hospitalized infants receive some sort of opioid at some point during their hospitalization, and about 0.8% of them receive methadone. Why is this a problem? Well, higher doses of opioids actually can impact neurodevelopment. Here's a very, very profound example. So a premature infant at 24 weeks to term, their cerebellum is supposed to increase in size 5-fold. In this study, they did serial MRIs of infants in the NICU, and they found that as the cumulative dose of opioids that an infant received in the NICU increased, their cerebellum size actually decreased. And remember the NeoPain trial? Well, they followed several of those children up at 5 to 7 years when they were in kindergarten and first grade, and they found that the children who had been randomized to the morphine group had smaller heads, lower body weight, poor short-term memory, and more social relational problems. So my lab's data, alongside all of this data, was used to build the foundation of the RR1 that I was awarded last year. So this RR1 is titled The Impact of Opioids on Health Outcomes for Hospitalized Infants. And I argued that critically ill infants, so these are the infants we are caring for in the NICU, with necrotizing enterocolitis, infants who are put on the ECMO circuit, they receive opioids during hospitalization, and they represent a population with significant opioid exposure that historically has been excluded from all of these studies. My central hypothesis is that opioid use varies widely for these high-risk infants, with higher use leading to substantial increases in neurocognitive disability and also healthcare utilization. So for this particular project, I'm merging 2 data sets. So I am using data from the FIS data set that I mentioned earlier from 9 California hospitals, and I'm merging it with a data set called the CPQCC. So this is the California Perinatal Quality Care Collaborative. So this is a data set that is generated from outpatient visits for high-risk infant follow-up clinics. So this captures about 90% of NICUs in the state of California and their high-risk infant follow-up. And so in these clinic visits, these infants actually undergo developmental assessments at 18 to 36 months. So what I'm building right now is a data set that is going to have clinical data telling me how much opioids or methadone hospitalized infants received, and then I also will have information on their neurodevelopmental outcomes at 18 to 36 months. And I think we all also appreciate that the population we care for is very expensive, and the opioids and the extended hospitalizations and potentially methadone utilization can make their hospital stays even more expensive. NICU care stays are the most expensive hospitalizations in the hospital. Many premature infants require months of care with costs exceeding over $300,000. And infants undergoing surgery, so our patients, are some of the most expensive patients to care for. So the implications of this study's findings are that we are going to identify a population of infants who utilize a significant amount of healthcare dollars and whose opioid exposures likely have a profound impact on early childhood development. This data will be used to inform quality improvement efforts, to minimize variation in pain management, and also will generate data to support payment policies that can facilitate long-term follow-up of these high-risk infants. So I'm going to switch gears now. I'm going to talk a little bit about how I built this grant and some of the things that definitely helped me create this area of work. One of the things I did very early on when I was a junior faculty member was getting a seat in the room where it happens, getting on an NIH study section. They have seats specifically reserved for early stage investigators, and this is so important because when you sit inside of an NIH study section, you will understand how grants are graded, you will see what a good grant looks like, what an unsuccessful grant looks like, and you'll understand the different funding mechanisms from a K-23 to an RR1 to an R21. It's also very important to leverage NIH funding resources locally. So a lot of you are affiliated with universities that have a CTSA. At USC, we have the Southern California CTSI. So this is a clearinghouse for lots of grant money that comes from the NIH, goes to a university, and people within the university can access that by applying for grants. So I received a team science grant from the Southern California CTSI. That team science grant funded the APSA opioid guidelines project that many of you are involved with, and also it funded a KL2 grant that supported a lot of the teen opioid studies that I have presented previously. So this demonstrated to the NIH that I could receive grant money and then take a project from inception all the way to publication, and further supported my application. The other thing that I encourage people to think about is building their dream team of collaborators, not just limited to their own institution. So when I applied for this grant, I drew from my collaborators from fellowship. I worked with Dr. Kate Deans, I worked with Dr. Jen Cooper, and they helped me hone my application, review my specific aims page hundreds of times, and present something that was tight and was readable and was absolutely executable. Also, I very much encourage people at the early stage to look to partner with people who are already NIH funded. In partnering with the CPQCC, I worked with Dr. Susan Huntz and Henry Lee, who run the CPQCC, who are already NIH funded, and their sort of stamp of approval on this project made it much more feasible to do. I also encourage people, if you are creating your project and grant based on someone else's work, you should reach out to that person. So I reached out to Dr. Anand. He is the one who ran the No Pain and the Neopain trial. And he said, absolutely, we are giving way too many opioids to infants, and this is the next logical step in this research. It's also really important when you present a grant to align it with NIH funding priorities and research that are already ongoing. So when I put this grant together, I highlighted that it really very much dovetailed the HEAL initiative at the NIH, the Act Now Collaborative, which studies neonates with opioid withdrawal syndrome, and also dovetails with the ABCD study, which studies adolescent brain development and substance abuse. And then finally, one of the most important things is to know your study section when you're submitting to the NIH. So I originally submitted my grant in September of 2020. For all of us, that was quite a year. And it was triaged and it was not discussed. I've met with somebody who had successfully been funded through that study section. They went over my grant. I resubmitted in 2021, and I was scored at the second percentile and funded last year. So a lot of this is science, and a lot of this is also grantsmanship. So use the community around you to support you. I've been supported so much by the people in this room. I really treasure the opportunity to talk a little bit about my work, and I look forward to your questions.
Our next speaker, Dr. Sathia.
Thank you so much. I definitely already feel like an imposter being up here. The work you guys are presenting is truly incredible. A sincere thank you to Dr. Kendall for allowing me to speak, for all of us to speak. I think the journey is what's important, and that's really what I'm going to focus on today. I'm going to talk about my research at a very high level, but I do want to focus on the journey in the interest of time. I have no significant disclosures to make. Now, before I tell this story, I think Dr. Kendall mentioned what is our biggest obstacle. And for me, my obstacle was probably similar to many of you, and it was honestly myself. We often think that there are certain things we can't do, that there are certain things that might take a lifetime to try to achieve, or certain problems that we don't want to tackle right away. And I've struggled with my own mentality, and at times have been my biggest obstacle. So I would start the conversation there, because I think there's a lot we can do when we shift the mentality of what we can achieve. Dr. Kendall eloquently spoke about firearms in kids. We all know this is a major issue. And in New York, we've seen a 350% increase in the number of kids we're treating with bullet wounds last year. One of the reasons I'm going to talk about my research first was that as I delved more into this field, it was startling to me that there are a number of evidence-based policies that we need to start working on and implementing, but there are also evidence-informed strategies that we know work, such as firearm safety counseling, screening for firearm injury risk, and violence prevention, that we as clinicians just don't implement in our healthcare institutions. For the last 10 years, only about 8% of healthcare workers across the country ever talk to their patients about gun injury. And if we can't talk to our patients about gun injury, we're never going to succeed in reframing this as a healthcare issue. This is not a political issue. This is really about safety. So when I got to Northwell, my research, and I'll talk about the journey in some subsequent slides, but this research study is really an implementation research science project focused on universal screening of all patients who come into our healthcare settings for gun injury risk. We want to integrate these strategies as part of usual care. So the impetus for this project is that we already ask questions screening for helmet wearing, drowning avoidance, substance use, behavioral health. Why can't we just ask questions as part of our routine practice when it comes to gun violence risk? This is a universal screening project. It's the first one in the country at this scale. And we have specific interventions, which I'm going to talk about very quickly. And then we're also doing a limited efficacy study of behavior change and outcomes in a cohort of patients who get the intervention. The goal here is to study the implementation of strategies, particularly as it relates to such a polarized topic, understand outcomes, does it actually lead to behavior change, and then eventually downstream reduction in firearm injury. But this is also a study in culture change at institutions, and how we can really normalize the conversation around such a contentious topic. For those of you in the implementation science world, this project definitely lives as a hybrid study. There's an implementation component because at times, particularly for an epidemic like this, we have to implement strategies even with imperfect science. But at the same time, we're taking a hybrid type 3 approach to also evaluate effectiveness for future downstream studies. We heavily relied on the consolidated framework for implementation research to really understand our healthcare institution. What are the barriers? What's the outer setting, the inner setting? Who are the stakeholders we need to actually get this off the ground? And one thing I was really naive to, I started my career doing health services research, data work, never implementation science, was just how hard implementation is and implementation science is, particularly as it relates to an issue like this. We then developed a protocol, right, after having all these meetings and understanding the stakeholders, a plan, and that is what has led us to now being able to implement this strategy. So I'm going to paint a very quick picture. A patient comes into our emergency departments or our trauma centers, and we're scaling this program. Right now it's just in the EDs, but it is scaling to the trauma setting. They get asked questions about firearm access and firearm violence risk. So these are two different things. They actually get a question about firearm access, and then they get a question from something called the safety score, which actually can determine future firearm violence. All too often, we lump it all together, and this naturally leads to a very confusing conversation for the public. So I think it's really important to break it down into these two areas. And if a patient screens positive for the access piece, they then get firearm safety counseling, they get gun locks, and so on. And I apologize for going through this quickly. And then if they screen positive for violence, that's where they get actual interventions like violence interruption and things that truly address the root causes of violence. You can't hand a gun lock or give a safety counseling course to a at-risk inner-city youth who's at risk of gun violence, right? That just doesn't make sense. So this is a comprehensive screening program that is aiming to tackle all elements of firearm injury. To this date, we have scaled to a number of other sites, but our main sites are 3 of our level 1 trauma emergency departments. 1 is a ped center, 2 are adults. We screen kids 12 and up. Multiple team members are involved. We've educated thousands of clinical team members as a result of this. We've screened 20,000 patients to date with thousands of interventions. And the results are going to be out in a few months, so I can't share those yet. I'm very early on in the process of this study. But I can say that screening at these sites is now part of routine care. Barriers have lessened. Conversations about firearm injury are regular. We even have a Firearm Safety Fridays where all the healthcare workers wear shirts, and patients actually expect to be asked. We go out in the community and they'll tell me, hey, I came to Northwell, why wasn't I asked about gun injury risk? So it's actually shifting the paradigm within the community as well. Now, my journey is important because I think it's a little bit non-traditional, and I'm certainly not as far down the road as many of my other colleagues here. But it started in 2019 when I got to Northwell Health. I never planned to be a gun violence prevention researcher. This was an area that I was interested in from an advocacy lens. But I had done trauma work, hepatobiliary work, but this was certainly not my plan when I came to Northwell. And I was inspired that when I got there in 2019, our CEO decided to take a big stance on this topic. He prioritized it at the same level of heart disease and cancer prevention. And, I showed up, second week on the job, I heard Northwell was having this big event, and I asked my chief, my very supportive chief, Dr. Prince, who's really a big mentor of mine, are we involved? And he said, no, I know nothing about it. So we knocked on doors, we went to the corporate headquarters, we found the marketing person who was running the event, who was Googling names to find who they should invite. And we kind of inserted ourselves in that process. And I think the beauty of the organization I'm currently at, and I will say is probably the most important thing that I hope our trainees and so on listen to, is that if you're at a place that respects young ideas and allows you to have a seat at the table, have a voice, and allows you to take risk, which is the current institution I'm at, that means a lot. And I would say that that is probably one of the number one things that I think has led to the success of our collective team. Second thing would be the actual team. So I'm proud to have my whole team here, despite drinking late at the night, drinking late night at the bar. They're all here to support me. Without a good team, not only can you not build your research career, but if you don't have a sound clinical career, if you don't offer good care to kids, it is that much harder to then succeed in the other things you want to do. And that's the way I feel. I know that my clinical job, my colleagues are amazing, so I don't stress about my clinical job that much, and that allows me to dedicate time to other things. Only going to focus on the research, so of course we all know there's a huge paucity of gun violence research. That's why this was an area of interest of mine. And the grant that I actually initially applied for, it's an interesting story. It's called an R61 grant. It lives somewhere between an R01 and a R21, R33 phased innovation grant. It is the size of an R01, but it has an innovation high-risk component. So what that means is that you might not need the same level of background evidence to be able to get that type of grant. And this makes sense in the field of gun violence, right, where we don't have that much data for a lot of things. And I came across this 3 months into the job, and I didn't know where to start. I don't know how many institutions have a gun violence researcher or the right mentor for this. So I just started seeking not the right way, they turned out to be the right collaborators, but different collaborators. And one of them was Tom McGinn at the bottom. He's no longer at Northwell, he's a CMO at Common Spirit. He's an implementation scientist, internist. I would have never imagined working with him, but he is multiply federally funded. He is one of the grandfathers of evidence-based medicine along with Gordon Guyatt, and he taught me a tremendous amount. He became a huge mentor of mine. Sandeep Kapoor at the top, he's the head of addiction services. I knew that there were a lot of synergies between the way that we treat substance use and the way that we need to be dealing with guns in a non-polarizing, non-stigmatized way. So we were able to bring him in. And through that process, we ideated on what a grant would look like. We only had 3 weeks to apply for the R61, never written a grant before, and in 3 weeks we were able to write it. And I will say this, a huge credit to the team, a huge credit to, I give a big credit actually to the pandemic because we were locked down, so couldn't travel, couldn't do anything else but write. So, but day in, day out, 3 weeks we were able to do it. And I think I have a background as a journalist, and I want, again, for the young trainees in the room to know, I think we underestimate the power of storytelling in grants, in our publications, because at the end of the day, a reviewer is a person. And the most powerful specific aims I have seen as an NIH reviewer now tend to have a very strong section on significance, innovation, and impact. And the way that you convey that message not only shows passion, but it shows direction, and it can really help a reviewer understand what you're trying to do, and I think that's where storytelling was, really comes in. And lastly, build your network, both before and after your grant. Social media, thought leadership, passion. The more you build your network, the more you build your name. People take note, and they look at your grant team and your ability to succeed, yes, but they also look at you as an individual, your passion for the area, just to make sure that they want to know that you can see it through. So thank you so much. Here are some QR codes for some of our center resources. Thank you.
Thank you very much. Dr. Talbot?
Morning, everybody. I'm honored to be up here with this fantastic panel and hope to do them justice as I wrap this up. I have no disclosures. I'm going to skip this, but I'm a surgeon scientist at St. Jude, 75% protected time. I can talk about that any other time. So I work in the field of CAR T-cell therapy, and for those of you who aren't familiar with this, CAR T-cells basically take the external recognition domain of a monoclonal antibody and transduce that signal through the cell membrane to the activation protein from the CD3 T-cell receptor. So basically, you get your input from the antigen binding your monoclonal antibody, and then the T-cell activates, produces inflammatory cytokines, and has cytotoxic activity. The important thing about these drugs is they're living drugs, and they actually have the opportunity to overcome some of the problems that immunotherapies faced in pediatric solid tumors, which are, these are immunologically cold tumors. They have a paucity of neoantigens to really attract the excitement of the endogenous T cells, and so we're trying to give them some of that. I work on attracting CAR T cells to tumors by taking advantage of mismatches between the chemokines that solid tumors secrete and then the receptors that the T cells have to recognize those proteins. So, and I apologize, this is going to be really fast. So we started by looking at RNA-seq data from 85 osteosarcoma patients in the Childhood Solid Tumor Network when I first started at St. Jude. And then we correlated that data with a protein screen that I developed where we take the media that the surgical specimen runs around the hospital in after you take it out. We recover that and do a protein screen looking for chemokine expression after the resection. And by doing this, we had a dually corroborated list of chemokines that are produced by these osteosarcoma tumors uniquely. And we were then able to identify that multiple of these receptors are not actually expressed endogenously on normal T cells. So I'm going to focus for the rest of the talk on two of these. One of them is CXCR2, which binds IL-8, and the other one is CXCR6, which binds CXCL16. So we developed T cells expressing these two receptors, not together, different ones on different T cells, and confirmed that we were able to see enhanced homing of these T cells through transwells to recombinant human ligands in a dose-dependent manner. But more importantly, we developed an assay, call it the HALO assay, which allowed us to quantify both the actual homing but also the kinetics by watching T cells come into a central tumor spheroid from a surrounding ring. So then we were able to corroborate this in vivo as well with luciferase-labeled T cells, and we were able to see that when given the chemokine receptor, they homed well to orthotopically implanted osteosarcoma tumors. So next step, pair it with a CAR. No, well, I guess, yeah, I can go ahead and start those. So we were able to use this in vitro assay to confirm that when you pair the chemokine receptor with a CAR, you actually see similar homing kinetics to what we'd identified without the CAR, but also that CXCR2 modified T cells actually started killing earlier than their corresponding others. So then we moved this in vivo, and we were able to recapitulate not only the in vivo homing activity that we saw without a CAR present, but we were also able to excitedly show that we actually had reduced nonspecific expansion of the T cells when there was a chemokine receptor present. And that really is exciting because it leads to a possibility for reduced toxicity of these therapies if we move them forward. And then we were able to confirm a survival benefit for chemokine receptor-enabled CAR T cells compared to CAR T cells alone in a pulmonary metastasis model. So this data is actually being presented in Los Angeles next week at the American Society of Cell and Gene Therapy, which is super exciting. And we're now moving this work into the immune-competent environment, which is really important to make sure you confirm not only anti-tumor activity, but also make sure you're taking into account toxicities and the effect of the endogenous immune system and microenvironment. And in addition to the chemokine receptor, we're actually adding a pro-inflammatory cytokine to the construct so that we're actually hoping to attract dendritic cells and other antigen-presenting cells into the dying tumor so that they can go back and talk to the rest of the immune system and hopefully produce a durable immune response. So I'm going to pivot now to Dr. Kendall's questions, one of which was, how did you get your question, which I phrase as, why do you put a surgeon in a cell therapy lab? And this really came down to me to the intersection of experience, mentorship, and opportunity. So I became interested in metastatic osteosarcoma as a surgical intern at Duke when I met a young lady with metastatic osteosarcoma in the clinic who ultimately succumbed. And I worked on metastatic osteosarcoma during my 2 years in the lab at Duke. So when I fast forward a few years, when I came out of pediatric surgery fellowship, still interested in basic science and osteosarcoma, my soon-to-become chair, Dr. Andy Davidoff, recognized that with a new cell therapy group beginning at St. Jude and a lot of institutional investment in that field, there was really a fantastic opportunity for me to join a growing field with an internationally recognized mentor, Dr. Stephen Gottschalk. Dr. Gottschalk then recognized that among his group, there was really no one working on chemokine-mediated homing, and it was overall unexplored as a field. And so he helped me to identify a way that I could really leverage my surgical expertise, including access to patients, access to samples, and preclinical modeling skills to address this question. So it was really a combination of things. Obstacles needing to be overcome, I would say probably the biggest one is really getting my own knowledge up to speed in this rapidly evolving field. I mean, it is just nuts how fast this field is moving, and I am not a PhD in immunology. So it really takes like pretty consistent dedication and self-education to get yourself up to speed on that. Getting adequate bench help, this is just so critical. You know, I hear a lot of folks come through the interview trail who say that they want to do basic science by partnering with a PhD. I'm just like, you know, those PhDs really have their own goals and career paths, and unless you're planning on hiring one, you're probably not going to get the support you need. And speaking of which, I am still hiring, so if anybody wants a job in my lab or wants to come to do a rotation in my lab, let me know. Appropriate modeling, so when you set yourself up as like the preclinical surgery person, you're going to get to do a lot of that, and it is time consuming. You know, I do procedures in orthotopic implantation, survival surgery, debulking of rhabdotumors, and amputations and such. And while this has led to my first PI paper as a PI, it also is very time consuming, and I'm really looking to offload some of that. And then time management, and if anybody out here in the audience really has anything to tell us, maybe you should come up here and take my place and let us all know how it works, because even with 75% research time protected and a super supportive chair and partners, it is really difficult. Who and what were helpful? I mean, you really can't say enough about the people. The theme of today, which is mentorship, and I have just had fantastic ones who go over and beyond, including Dr. Gottschalk and others in his group. Collaborators as well, who really move your work into arenas that you either by access or understanding or training don't have access to. And then our support clinically, which really allow me to be in the lab when I need to be. And then resources, the startup funding is really key. Funding begets funding, and having a person at the bench is really important because data begets data. But in addition to those obvious things, I mean, I think the strategy, so become the person at your institution or in your scientific group who is the point person for that niche. So at St. Jude now, I'm the chemokine person. I got a package directed to the chemokine scientist at St. Jude the other day. And I am the preclinical surgical modeling person. And so that's really allowed me to do a couple of exciting collaborations which have come out recently and to diversify my research effort. Speaking of which, I've given you my most mature work, but I'm really super excited to be moving into a number of other projects, including structurally modifying these chemokine receptors to make them work better, doing preclinical work to support early adjuvant CAR T-cell therapy after R1 and R2 resections for chemo-insensitive sarcomas, and investigating the microenvironment to understand that better and how we can manipulate that. Just a quick note about my funding. I'm funded through the NCI Early Stage Surgeon Scientist Program, which is a sort of pre-KO8 award, and it's an administrative supplement to the Cancer Center P30. There's one nominee from each center, and 12 are selected in the year. And it's similar to the KO8 and other multi-institutional career development grants. So I just want to make sure everyone in the room knows that it's a 50% time commitment now for surgeon scientists as opposed to 75 for these career development awards. But you still really have to have a very robust career development plan. They do care. You need to identify your areas of weakness and tell them how you're going to fix those. So these are just my acknowledgements and funding sources. I'm super excited to tell you all about all this, and I'm happy to take any questions.
Firstly, I want to thank all our young investigators who did what I asked them to do, which is to share their individual passions and how they got on the first rung of getting them on the road to implementation. We do have a couple of minutes for questions from the audience. Dr. Besner?
First, I just want to congratulate all of the panelists, and it really warms my heart to make me believe, listening to your talks, that the surgeon scientist is still alive. I have a question for Dr. Kelly Kwan. So, for those, and this applies to everyone in this room, who take care of patients with necrotizing enterocolitis, and those who do clinical and basic science research in that area, we have been led to believe that The neurological sequelae that these patients exhibit once they grow up and can be tested is due to the gut-brain axis. And we think that inflammation in the intestines with dead and necrotic bowel affects their brain development. But now you've really led me to believe and to wonder whether the incredible doses of morphine that these patients are getting, because they have quite often multiple operations and they're in pain and they're intubated for a long time, may play a role. So do you think your research will be able to tease out how much of what we're seeing is due to the gut-brain axis and how much is due to what we're doing to them by giving them a lot of morphine? Thanks for the great work from all of you.
Of course. Thank you, Dr. Besner. Dr. Besner has been an incredible support for me in particular from when I was a fellow, so I very much thank you for that. So I think that in the way we care for neonates, we just don't know what the sweet spot is. We have to give them pain control, but we can't go one side not sufficient pain control or the other side too much opioids. I think there's a significant component that is due to overuse of opioids, and my hope is that in this study we'll have a better idea of what the sweet spot is. The other thing that I haven't addressed in this grant that I'm writing another R01 right now for, I think there's a significant pharmacogenomic component to this. There are receptors and that are coded in the human genome, as we all know, that specifically are related to metabolism of opioids, and there are certain individuals, and this can affect up to 25 to 50% of the population, and depending on how that receptor is coded in your genome, that can impact how much opioid stays in the serum of your body and it is exposed to the infant brain. And I think that that also has a significant component of the variation, driving the variation we see in opioid use. So it's one, from the physician themselves, two, from their clinical status, and three, I think there's a genetic component driving this as well. So more to come.
Brad Warner, St. Louis. Congratulations on all of your work, and I echo what Gail just said in terms of, physicians, scientists, surgeon scientists are there. I want to underscore the fact that it's so impressive to me how diverse all of the projects that you are doing, covering social issues, bioinformatics, basic science, and clinical outcomes. And so I think that's really a great representation of what we can do. And I would just make a comment that I think, number one, persistence and perseverance is critical, because there's all barriers to doing what you do. We get clinically busy, we get distracted with doing other things, but the fact that you guys have been able to persevere despite all of that is very impressive. And the other thing that I would say is, really, it's great to take advantage of the mentors or collaborators around you that you might not, as has been mentioned before, otherwise talk with in a hallway. But identify them, and I think being a surgeon, I do think that you bring something to the table that they don't have in terms of specific ideas or models. So keep it up. I think that's really spectacular. And thank you, Jessica. This was really a great way to introduce and maintain viability of research in pediatric surgery.
We are unfortunately running slightly over, which I thank the audience for indulging us on. I do want to recognize each of these investigators who I think did a spectacular job of introducing us both to the areas of their passion and the mechanisms of their perseverance. And so let us recognize them. And then I have a plaque for each of you from APSA to recognize your contribution. Dr. Booker? Dr. Kelly Kwan? Dr. Sathia? And Dr. Talbot. We will now move to two more of our tech talks.
I'd like to invite Dr. Pramod Puligandla to introduce the first speaker.